So we're moving on in Chapter 10 to our more cognitive-based neurological disorders. So this is pages 343 through 358 in your textbook. When we're talking about cognitive communication disorders, obviously we have different types. The three that we're just going to focus on for this class is right hemisphere disorders, TBI, and dementia. When we think about cognition, we also have to think about language and how the two affect each other. So a good way to think of it as they are partners, right? We have to have cognition, or our ability to acquire and process knowledge about the world, in order to produce or acquire language. In the same token, we have to be able to have meaning and be able to hold conversations and communicate with others in order to expand our cognition. So just like we had talked about before with language having different domains and they have a hierarchy to them, cognition also has different areas and they have a hierarchy. So beginning at the bottom, we have arousal. So this is just being awake and alert, right? When you wake up in the morning, you're aroused, you have the energy to get out of bed, you know what you need to do for the day. And then we have orientation. That's knowing where you are in a certain place in a certain time. So are you oriented that you're in a classroom, or oriented that you're in your bedroom? Are you oriented that you're in the library on campus? Are you in a coffee shop? Are you in Louisiana? Are you in another state? All of that goes into orientation. Once you're oriented, then you can have attention. And there's 4 different types of attention. We have selective, divided, sustained, and alternating. So think about how attention can really affect the way that we move up that hierarchy into memory. So if we're using divided attention, meaning we have 2 things going on at one time, and we're trying to give attention to both of those things. So for example, we're reading a book while someone's talking to us. We're not going to be able to remember what's going on in our book and the conversation we had with that person, because we can't hold on to both of those things at the same time. We're taxing our attention area. And so when it goes to be stored into memory, it might either be partial memories or incomplete, or it might only stay in our short-term memory and not get stored long-term for the long-term memory and retrieval for tomorrow or a week from now when your friend asks you what they were talking about. Above that, we have inferencing. So we're able to remember things that are going on around us, but can we inference or interpret what some of those things are? And then we have problem solving. So the ability to figure out, what we need to do. If we're running late for class and we need to get gas and want a cup of coffee, then we can figure out, I don't have time for that cup of coffee. I have to get gas, otherwise I'm not going to make it to class. And then maybe I'll just be a couple of minutes late, and that's okay. And then you have the problem solving of, well, I'm already going to be a couple minutes late because of getting gas. Maybe it's okay if I'm a couple minutes late for getting the coffee too. So all of that goes into problem solving. It can be bigger things as well. And then we have executive functions. And executive functions go into time management and different things. We're not going to talk about those in detail, but just know that these are the certain levels of cognition and how each one affects the other. So the first cognitive disorder we're going to talk about is right hemisphere disorder. So we've talked about things before, mostly on the left side and what it has to do with language, but we're also going to think about the past and the future, right? So these are the extra things that the left side is responsible for, and that really goes into our memory, right? Our long-term memory, and also for our planning. On the right side, we have more of our nonverbal information, spatial relationships, voice tones, and so this is where it has to do with communication, but it's kind of an indirect path. And then we also have to think about thinking in the present, or as far as our short-term memory goes. So a right hemisphere disorder can be caused by many different things, and its causes are pretty similar to aphasia. The only difference is that it's damage to the right hemisphere, and it can be anywhere, any lobe in the right hemisphere. So again, just like aphasia, it's acquired and non-degenerative, meaning it doesn't get worse over time. But instead of being damaged to the language area of the brain, it's just damage to the right hemisphere. So anything that causes that damage, like a stroke or trauma, seizures, infections, can give you right hemisphere disorder. And then if you're thinking about dementia, if there is a part of the brain that is breaking down over time because of dementia, that would change it to a degenerative acquired disorder. But for the sake of this class, we're just going to think about it as an acquired non-degenerative. And we'll talk about dementia separately. So the deficits for right hemisphere disorder really depends on the area that's damaged. So remember we talked about the different functions of the lobes. Well, it just depends on if it was damaged to the frontal lobe, they're going to have more motor deficits. If it's damaged to the parietal lobe, they're going to have more sensory deficits. If it's damaged to the occipital lobe, they're going to have more difficulty with vision. And so overall, remember that it doesn't specifically result in a language impairment, but it can affect language use or the ability to communicate overall. So this is a summary over here. On the right side, we have just the left side, what we've talked about before, the functions and the different injuries that go along with that. And then on the right side, all of these things. So the right side is really organizing information, getting abstract meanings, providing context, the spatial relationships again, visual information, facial recognition, intuition or emotion, and then remember we have that crossover where the left side of the body is controlled by the right side and the right side is controlled by the left. So one of the things we're going to talk about is not only impairment in attention but left neglect. So this is where there's damage on the right side and the person actually doesn't recognize that things are happening on the left side of their body. And this isn't a blindness on the left side, doesn't mean they can't see, they just don't have that attention to give to the left side. Then we have our visual perception, right? So the facial recognition, think about how that can affect communication. If you're talking to a loved one and you don't recognize who they are, or you're talking to someone who's trying to help you and you're in a difficult situation, it can cause a lot of issues there. And then we have attentional deficits. So at the most basic level, if we're talking about trouble with attention, it could be trouble maintaining a topic. It could be trouble maintaining attention just to have a conversation, so turn taking. Can they maintain attention to look at you while something else is going on in the room, or talk to you when there's background noise, and that can break down communication. Then there's disorientation, where they don't know where they are, they don't know who's around them, and so that can be very limiting when it comes to communication. If you don't know where you are, you're not going to be in a very calm state to be able to express yourself and describe what you need. And then there's affective deficits, so just the emotions and expressions. Sometimes these people have outbursts, particularly if there's damage to the frontal lobe where they get upset very easily or they get upset for no reason at all. They may yell for no reason at all, and they may yell at inappropriate times. So ultimately, all of this affects the pragmatics. So taking turns, staying on topic, maintaining eye contact, having appropriate behaviors or comments, and then that reasoning, planning, and problem solving. So things like going to the grocery store and knowing that you have $20 but you have 17 things to buy. Trying to figure out what is the most important thing to buy can be a problem that they have. All right, so now we're going to move on to traumatic brain injury. And so you can see over here, these are different types of traumatic brain injuries and the areas that they affect. So it can be anywhere in the brain that has received some type of trauma. So again, TBIs are acquired non-degenerative, meaning that they don't progress over time, but it is injury to the brain because of a physical trauma or external force. The damage of a TBI really depends on how it affects the nerve fibers. So remember we said that nerves create a network, and then each network is responsible for different roles. And so if you have a network that has been stretched, it means that that path has gotten longer. It's going to take longer for that message to get from the brain down to the lips or the tongue, or from the brain to be able to put a sentence together. If they're severed, then that means that that bridge has completely broken, right? That means that one half of the communication pathway can't talk to the other half, and so either they can recreate a pathway around it, or there might not be any recovery at all. So it's going to be very, very limited. Again, it might be very, very slow if it's recovered. TBIs are highest in 15 and 19-year-old males, and also in very young children. And you think about the causes of a TBI, it really kind of makes sense, right? It can be anything from car accidents or bike accidents, from falling, any type of abuse, or fighting. It could be war. It could be a gunshot. It can also be just during general sports and activities. So concussions are actually a form of a traumatic brain injury. When we talk about the different types, we're going to divide it really into two sections. We have our acceleration, deceleration, and non-acceleration, and then the other types is the penetrating or non-penetrating. So for acceleration, deceleration, that essentially means that the head is moving, and then the head stops, making the head stop, and the brain goes backwards or sideways. So these are the type of injuries most commonly seen in car accidents. When the head is moving in space, that stops, right? So you're jerked forward, you hit either the seat belt or the dashboard, and then the head goes back or to the side and hits the window. And so it's called a coup contre coup, meaning that you're hitting the front and then the side. So for these types of injuries, they're most commonly, again, associated with car accidents, so they're either going to have frontal temporal damage or frontal occipital. And then for the non-acceleration, it means that there's a strike to a stationary head. So this is either a gun, a bullet to the brain, it could be a bat to the head, it could also be a golf club to the head, anything where the head is still in space and something comes and strikes it. Now from there, you can have a penetrating or non-penetrating injury. So you can have an acceleration, deceleration, penetrating, or non-penetrating, and a non-acceleration, penetrating, or non-penetrating. And all that means is if something entered the brain or not. So for penetrating, it means that something went through the skull and hit the brain, and all of the meninges or that protective layering over the brain was torn. For a non-penetrating, this is a closed head injury, meaning that there's indirect damage to the brain. So nothing went into the brain, but because of bruising or swelling, things like that, where your brain has been shifted within the skull, there's been injury to the brain. So essentially you have intact meninges. Now, as far as the TBI deficits go, it's again very similar to right hemisphere disorder or aphasia. It just depends on the impacted area. So if we're looking at a frontal temporal damage, then it's going to appear more like aphasia if it's on the left side, or it might appear more like a right hemisphere disorder if it's on the right side. Essentially, overall, you're going to have physical, cognitive, language, and behavioral impairments, meaning that they are likely going to have some type of paralysis or paresis. So paralysis meaning that the arm or the leg or part of the body doesn't move at all, or paresis meaning that it has partial movement or very limited movement. And then from the cognitive, they'll have deficits in attention or memory. If they have deficits in these lower areas, they're probably going to have deficits in the higher functioning areas of executive functions or inferencing. They'll likely have difficulty with language, either with the topic maintenance or speaking of appropriate topics. And then behavioral, if they have trouble with maintaining their emotions. So this is where the outbursts come in. Or it could be being very melancholic, so it's difficult for them to get excited about something. For the treatment for right hemisphere disorder and TBI, essentially you just have to know that recovery is a slow process. So it's not that different from aphasia, we're just targeting a different area. So again, we have neuroplasticity, meaning that we could have spontaneous recovery in the first few weeks up to the 6 months, and then everything remains stable for the next after the 6 months. So our treatment plan relies on the results of the assessment. So we find what areas they have deficits in, right? Is it cognitive domains, or is it language domains, or both? So we do our assessment, we establish the baseline, we set goals, and we do a continual treatment and assessment, and then we plan for discharge. The intervention is most typically a multidisciplinary intervention, meaning that they're getting physical, occupational therapy as well as some type of medical intervention. Ultimately, we're trying to reduce social isolation and increase social participation. And then for behavioral treatment, we want individualized functional communication. And then we're structuring treatment so that we can have a select stimuli and provide feedback, increasing that complexity over time, and provide compensatory strategies if they need them. So all of this is, again, very, very similar to aphasia, just targeting different areas. Now we're going to flip to dementia. So we're going to look over here at this picture. This right picture is a normally aged brain, and you see how full it is and how healthy it is. And then over here on the left, we have the brain with Alzheimer's dementia, and you can see it's missing a lot of that white matter, meaning that a lot of those networks aren't there anymore. So dementia is a gradual deterioration with associated negative changes in behavior. So there are temporary dementias, meaning that they're reversible, and it can be due to drugs or drug abuse. It could be because of lead or mercury exposure or poisoning, kidney or liver disease, endocrine disorders, or a brain infection. So that doesn't mean that the person can go back to 100%, but they might return to 95 or 80%. Down from a 50% functioning. So their brain's not going to just magically fix itself, but it can improve. The other type is the more commonly heard of, and that's the progressive dementia, and it's irreversible. So there's just a persistent progression of deterioration in intellectual functions and behaviors. So this is the one most associated with the elderly, and there's not very much that we can do to stop the progression of dementia, but we work with the progression. There are different types of dementia. The one that you hear about the most is Alzheimer's disease. So Alzheimer's, it does not equal dementia. It's just a subtype of dementia. So you may hear it as Alzheimer's disease or Alzheimer's dementia. And sometimes you hear them interchangeably, but know that they're different. The associated dementia associated with Pick's disease is frontotemporal dementia. And then there's also dementia specific to Huntington's disease, and then there's Parkinson's dementia. Creutzfeldt-Jakob disease has a different presentation of dementia, as does AIDS, and if you acquire dementia because of a TBI. And then there's also vascular disorders or strokes that cause vascular dementia. And the reason you need to know this is that dementia can present itself very similarly, but it doesn't mean that everyone with dementia has Alzheimer's. So think about someone who has frontotemporal dementia. They're likely going to have more of those behavioral components where they have outbursts, or they get upset very easily, or they say inappropriate things, or they have trouble with planning or understanding what's going on around them or being oriented, versus somebody with vascular dementia. So this is someone who has small strokes over and over again, causing damage to the brain. It's going to be a more diffuse presentation, meaning that they're going to have difficulty in a lot of different areas. If you're interested, there's a link down here at the bottom for the different types of dementia, and it'll give you a good description about them. I just want you to know for the class that there are different types, and that Alzheimer's dementia is not the only one. So there are different symptoms for dementia, and again, it's very gradual over time. The most alerting one that you notice first is obviously the impaired memory, and it's more with short-term memory. So these are the patients that are going to remember what happened 50 years ago, but they might not remember what they had for breakfast this morning or what happened yesterday. They can also have problems with reasoning or judgment. And so this could be someone who is trying to get outside of their nursing home, and so they climb up on top of a stage even though they need to use a walker to walk, and then they fall off of the stage. They could also have difficulty with orientation, so knowing that they're in a nursing home and not at home. This can be very alarming for somebody who went to sleep and doesn't know when they wake up in the morning that they're still in the nursing home. Ultimately, they can have limited ability to complete activities of daily living, so getting dressed, brushing their teeth, making coffee, or making any type of meal can really be of detriment after having symptoms of dementia or progression. They can also have depression or mood swings. This can be associated with just the initial diagnosis of dementia. It can also be part of the progression. So if they're exhibiting more depression, larger mood swings where they're going from very, very happy or very, very sad, it can be a sign that the dementia is getting worse. And then for later symptoms, they can have delusions or hallucinations, very large emotional outbursts, or paranoia. And so this is where they may get scared, they may attack somebody, and different issues like that. So thinking of these types of symptoms, how communication can be impacted. For somebody who doesn't remember what they had for breakfast, being able to talk about what they have to do for that day or talk about what they did the day before can be very limiting. And so they'll often bring up things way in the past, and they might be completely off topic. So you might be talking about what they need to do for when you're in clinic, and they start talking about fishing with their nephew 15 years ago. And then for comprehension, they might not understand what you're trying to tell them. They may not know where they are. And then they may also have an odd sense of humor or not understand humor. So if you make a joke, they might be offended by it. They might make what they think are jokes that don't seem like jokes to you, or they may laugh for no reason at all. As far as naming goes, it can be affected by their vocabulary, so they can also have verbal paraphasias. And then later symptoms where their speech production or their grammar or autonomic speech, like good morning or how are you doing, I'm doing okay, can really be impacted, where they aren't able to do that anymore, or they're going to more autonomic speech where they're only saying very automated messages. They can also have echolalia, where they repeat others. So if you come in and say good morning, they might say good morning 15 more times, or they might say good morning for the rest of the day. They can also have palalia, where they repeat themselves and say the same message over and over again. So for the treatment of dementia, it's going to be different from our aphasia, right hemisphere disorder, and TBI, because we can't reverse dementia, and it also can't be checked. So dementia is actually diagnosed with an autopsy, but you'll also see dementia thrown around as a diagnosis anytime someone has the common symptoms when they're in the hospital or when they're in nursing homes. So as far as clinical management goes, they do receive medical management, but it's not a fix with a medication where one day they're just not going to have dementia anymore. They're typically on antidepressants or some type of neurological medication to slow down the progression as much as they can, but ultimately it's going to continue to happen. And so we have to give caregiver education and patient education of what to expect with the progression of dementia, and it comes with its own hazards. So some people don't want to know what's going to happen, and other people really want to understand it. But what you have to stress to them is, that it is a progressive disorder. We're going to do what we can and make them comfortable while we can, but ultimately we have to make sure that they are taken care of and that the caregivers are taking care of themselves. And then we also do behavioral strategies. So rather than selecting specific targets or treatment protocols that break down each and every component of cognition or language, what we're ultimately going to do is provide them ways to continue to communicate. So that can be with photo albums or picture books. We can modify their environment to make it more easy for them to get around and communicate with other people. And then we can also teach the family members to provide cues to help them maintain topics or get the communication across that they need to.